Good day and welcome to The Internist. I'm Henry.
And I'm Christiana.
And we're medical students from Amsterdam who would love to take you on a journey through the fascinating world of clinical reasoning. Today with us we have Dr. John Harrison. Dr. Harrison read medicine in London, graduating in 1984, after which he trained in general medicine and endocrinology, followed by a period of research into diabetes at St. Thomas's Hospital, London. He trained in general practice and developed new ways of delivering care for diabetics, in addition to developing research interests in osteoporosis, specifically focusing on the assessment of bisphosphonate. Dr. Harrison worked for over 30 years as a partner in general practice in Northamptonshire, in addition to specialising as an endoscopist in the John Radcliffe Hospital, Oxford. Dr. Harrison is a founding director of Principal Medical Limited, a healthcare provider and general practice membership organisation that is committed to working with local clinicians to deliver high-quality patient care within a range of community-based healthcare services. He's director of Pharmacy of Occupational Health Organisations and provides clinical leadership into frailty work for Northamptonshire ICS. Dr. Harrison is a member of the Royal College of General Practitioners and a fellow for the Royal College of Physicians. Now, welcome.
Thank you.
Before we start with the cases, I would like to know why you chose general practice.
Well, general practice was a difficult choice for me when I was a young doctor. I was drawn into general medicine because I really enjoyed it. It was exciting. It was exciting to be what was a medical registrar at that time. And I fed myself through the London hospitals and just absolutely loved every day of my life. But then when I became a little bit more senior and got into research and started to stare at what being a consultant would mean, it would have meant two things. One, I stayed in London and did the really interesting endocrinology. And I knew that I didn't want a life in a major city. And the alternative is to move into a more peripheral hospital, and the life there is diabetes, a little bit of thyroid disease, one or two other things, but mostly diabetes. And at that stage in my life, I felt that was too restrictive. I wanted to be a little bit more expansive than that, and the opportunity of being self-employed in the community and doing some different things was attractive.
Let's then dive into the cases. Should we do that?
Mm-hmm.
Perfect. Okay. First off, we have Marianne. She's 89 years old. She lives alone and has type 2 diabetes for the last 12 years. Her general health is poor and she has extremely limited mobility. She's just moved to be closer to her daughter, and this is the first visit to this practice. Her glycemic control has slowly deteriorated in recent years, with a HbA1c measurement of 72 millimole per mole, despite continued use of metformin, 1,000 milligrams twice daily, and insulin, long-acting 10 units per day. Her lipid profile is well controlled on stimvastatin, 40 milligrams at night. Other readings include an EGFR of 48, full blood count, liver function tests, and thyroid function tests are normal. The albumin-creatine ratio is 6.3 milligrams per millimole. The blood pressure is 142/68 on Rampril 10 milligrams once daily. Her BMI is 27.3, and she has a background in diabetic proliferative retinopathy. She struggles with self-care and worries about her diabetes into the future. So you see this patient in the practice, and the first question I have is, what's your initial thoughts?
When we see somebody like this for the first time in the community, we know a lot about them by the time they walk through the door. So the way they carry themselves, who they come in with, whether they come in a chair, whether they come in with their daughter, whether they have other family support, all of that becomes apparent as you see them walk in the door. And there was an old adage in medicine is that you're supposed to understand, at least within a range of possibilities, what the diagnosis is by the time they sit down. It's not quite the case, but there's a lot of information to draw just before they sit down. And then the exploration is deepened by some of the initial conversation. So where they've come from, why they've come up, some of the detail that you've outlined in your what happens after that, and you've started to develop a relationship with them. And I can't tell you how important it is to do that. They're eyeballing you for the first time as a doctor, and they're working out whether they can trust you, whether you know anything about the subject that really matters to them. And they also want to know whether you're interested in their particular condition. They'll know very well that not all doctors are good at one thing, and they might be better at another, and they'll want to know whether you understand them, whether you understand their plights in life, the things that they're really worried about. So I'd say those are the absolutely fundamental core things to do when you meet somebody for the first time, regardless of what their diagnosis is, but particularly when they've got a chronic and enduring illness. And diabetes is certainly in that category. So once you've established that rapport, the next thing that's so very important is to understand what their agenda is, and you, I think, will know that the agenda of the doctor is very often very different from the agenda of the person coming in. So what we don't understand at that early stage is what they're really bothered about. They've obviously come up to live with their daughter, but they may have all sorts of health understandings, health experiences, and they may come just bothered about one thing. It might be that they can't see, for example, the insulin syringe to give the right dose, and they need somebody to help them with that. That might be their overriding concern. It might not be yours as a doctor. You might be sitting there thinking about the lipid profiles and the cardiovascular risk and all those medical models of illness, but they won't have those medical models of illness. And so there's an initial exploration about where those two intersects are.
So these concerns are a lot of times have to do with daily activities that they just can't perform or are limited to.
Yeah, those are the important things in their life. They won't be worried about the 20-year vascular risk profile. And
then how does one get closer to what is actually important to a patient in practice?
So after you've developed that relationship and a little bit of understanding and some trust, and that takes some time. It may not occur on the first consultation. Then there's an exploration which is what matters to you most. There's some of those open questions that you might reveal their key issues, and it's really important to start with those, because if you don't address their key concerns, she'll walk away feeling that she's not had airtime, she's not had her issues addressed. So some of those fundamentals about the doctor-patient interpersonal relationship is key at this stage.
But how would you do that? What kind of cues would you use? Kind of sentences?
Yeah, I mean, this is a massive topic, isn't it? Not specifically around diabetes, but I would say, if I look back over my 30 years of life, the thing that I've got wrong most frequently is that assessment of the person in front of me. There's such a huge range of different intellectual abilities, different understandings, different backgrounds, and if you misjudge that, I have made mistakes in the past, and we can all make mistakes very easily if we just get that wrong. But it's an understanding of who the person is that's so important at this stage.
So we're talking about that you focus on who the person is and what their agenda is, but how long do you have to figure that out?
Yeah, it's a really good question, and some of that comes down to the organisation of the work in general practice. And if you know this is a new person, and particularly if you know they're coming in with relatives and there's a complex history, you'd want to extend it beyond the usual quarter of an hour, which is the standard in the UK. It's the standard consultation time in general practice. So what I've done all my life is made sure that's doubled at least, and sometimes more than that, and also to have the availability of some of the other people within the practice that deal with diabetes. So there's always a diabetic specialist nurse who will introduce herself and then set up a program with the individual afterwards. But you can't do this in a short period of time. It always takes a lot of time. The question that you asked me before is what's then going through my mind as a clinician is two things. The first, this is the medical model being imposed on the background of her submissions to you. Two things is how they manage at home, why she's moved up here, what's the extent of her care requirements at home. Are they all sorted? Does the daughter do it all? How easy or difficult is that going to be for her? Is there a long-term sustainable future in that? Is there any more support that she needs? And then from the purely medical point of view, it's quite unusual to have somebody on metformin and insulin, and particularly if if she's got significant visual problems, and that's something I'd want to explore with her. We don't know that just now. The use of insulin will be difficult. The use of insulin syringes, unless there's a specific click type syringe, will be difficult. And then there's the question of whether the daughter who she lives with can do those injections. She might need training to do that. She might need some encouragement. She may be unwilling to do it. So there's a bit of an exploration around that, but only as a prelude to thinking about whether she actually needs the insulin or not, and starting to understand whether that's the case. 10 units is a relatively small dose. And that regime might have been in place for quite a long time. We would more normally add an SGLT2 to that regime of metformin. Nowadays, the last few years, we would have done that. And I'd want to go back through the history and see if that's been tried, if there's any reason why it wouldn't be the case. And that's an important drug in this circumstance, recognizing her deteriorating renal function. There's significant renoprotective effects from that class of drug.
Mm-hmm. And what I hear right now is that there are a lot of different things that could happen, and you try to prevent. And you said what the person needs, but how do you figure out what the therapeutic goal is, and what are you going to focus on? And
prioritizing really.
That's exactly what the next thing to do is to agree between yourself and the person what the key priorities are. You can't possibly deal with them all on the first occasion. And this is where medicine's so very different in the community, because you start a long-term relationship with somebody that depends on mutual trust and requires you to deal with things that are really important for them. In hospital, you see people occasionally. The next time it may be somebody different, and it's a much more medical model of illness. This is a socio-medical model that needs to be absolutely what the patient wants and needs, perhaps more importantly than what the doctor wants.
Mm-hmm. And I can imagine that you see quite a lot of patients that look like each other, in the sense that they're old, they have a lot of comorbidities and things like that. Mm-hmm. So how do you place your mindset into changing, okay, this is a different patient than my previous one, so I don't need to give the same treatment and support that? How do you figure out? Yeah,
it's a really good question. You have to be a chameleon in medicine. You have to change your approach for everybody who comes through the door. And that's so very difficult. You know, in some respects, it's an act. The role is an act, because the person in front of you wants you to behave in a particular way and has an expectation of you. And that expectation will be different for a teenager compared to an elderly lady of 70 odd. So you've got to. Comes down to what I was saying. When the person first comes in, you gain a very rapid impression of who you might be dealing with and what the context is, and then you have to morph your own behaviour towards that person. It's quite an art. But
morphing your behaviour towards that person actually causes that person to also give you different information than if you had a different approach to it.
Absolutely right. Okay. Absolutely right. Exactly what you do will be mirrored by the person in front of you and the relatives in front of you, and defines the information that you can get out of that individual. It's an absolutely fascinating dynamic.
Oh. I got a question about there's a patient who's new in the practice. She's complex history, and you have questionable drug decisions. How do you then start fresh on a complex case that comes in, and without the insight to being able to see, okay, why has someone previously done this choice and this choice? How do you approach that?
This is getting easier in the UK because medical records are transmitted electronically. In the old days, and I mean 10 years ago, we had to wait 6 weeks to 2 months before we were able to get any medical information. And what that generally did, unless the person brought that information with them, or was a very good historian, was meant that we had to just play for time until we had any accurate information. So that sort of information that I was describing about what the reason for an unusual drug regime would be very difficult to get. Now it's much easier to get, and you can usually trawl through very quickly what's happened in the past and start to understand it. What's difficult is that the medical records are very often incomplete, and an explanation of why those decisions were made is very often not there, and the person in the circumstance is likely not to be able to be very clear about why that's occurred. So you end up making a judgment about what the existing arrangement is and thinking about whether that's something that you want to continue or want to change. But the changing of medicine at an early stage in a consultation and an early stage in a relationship with a patient is very difficult because that trust hasn't been established and they've been well controlled with their previous doctor. So you've got to gauge when and how that transition is made, particularly for something substantial that's been in place for a long period of time.
Okay, so now if we look at concrete steps, the first consultation, what do you do before she leaves the room or after she leaves the room? What's the concrete treatment?
So the things that I would nearly always want to do in this circumstance is introduce them to other members of the team that would support her. And that's particularly important around education. So there's a shared understanding of the diagnosis. We understand what she knows and we augment that where we can. And she understands what we can offer and who else is involved in her care. So when things get difficult, we don't always want her to come to the doctor if it's just about some details of her care, where she finds the chiropodist, that sort of thing. Needs to go elsewhere, and she needs to understand the other team members. So she needs to feel secure. She needs to know that there are people there for her, and she needs to know where the best port of call is. Not always to make an appointment with the doctor. There are some things that we're very bad at. So that's number one. The second is to signal to her that I'd like to look at the way she's treated, because the ongoing management with insulin is likely to get more difficult as she gets older, and I think there are other options that need to be considered.
Well, we have like a very detailed medical profile, but what do these numbers tell you, or how do you approach them?
Yeah, it's really interesting, isn't it? Because the detailed medical profile in the initial phases of the meeting with a new person, unless it stands out at you, can be put on the back burner. So, diabetes is all about cardiovascular risk. It's that's why we do what we do. It's not about controlling the blood sugar; it's about cardiovascular risk and other risks. So what a liver function tests are like and what a blood count is like, and to some extent, what our EGFR is like. That's down a little bit at the moment can take a back seat. The EGFR being low is another reason for changing a medication line. So what we're doing here is picking off the things that are, from a medical perspective, probably the most important, making her feel settled, and then setting the ground for being able to make some changes if we feel we need to later on.
So she is worried about the fact that her disease is being worsened as the time goes. So my question is the goal as a doctor to stabilize the disease or to even slower the progression? And how do you tell that to a patient?
Well, that of course is the goal of the management of diabetes. But in this particular circumstance, it might not be the overriding goal. There is a straight line graph between blood glucose and cardiovascular risk. It's very clear. But somebody who's elderly, immobile, and at home, and with a limited life expectancy, that may not be the preeminent consideration. It may be quality more than quantity.
Okay, then on to the second case.
Abid is a 47-year-old with type 2 diabetes for 5 years. Abid's current treatment consists of metformin 1 gram twice daily, glycoside 160 milligrams twice daily, and atorvastatin 20 milligrams once daily. His HbA1c has been measured at 65 millimole per mole, EGFR more than 90 millimole per minute, cholesterol 4.2 millimole per liter, non-HDL 2.2 millimole per liter, blood pressure of 136 over 86, and BMI of 29.4. Abid works long hours as a chef in a busy restaurant. His irregular work schedule often leads to inconsistent meal times and difficulty in maintaining a balanced diet. Abid reports limited physical activity due to his demanding work hours and fatigue. He acknowledges his struggle to find time for exercise amidst his hectic routine. During his diabetes review at the GP surgery, he mentions that Ramadan is approaching, during which he plans to observe daytime fasting. He asks for advice in managing his diabetes around the month of Ramadan. Okay, so a major problem here is that the person has very hectic lifestyle, so we can't really expect him to follow the regime that we as a doctor will prescribe, let's say. So, and how would you give advice that could fit with his life?
Yeah, this is this caricature that you've described is a really common one, and more common amongst men than women. They're risk takers, men, more than women are. And in this circumstance, the issue about the long term may not be front and center of his mind. He needs to earn a living. He needs to do a job. He's very stressed, and he can't find the time to look after himself very well. And I think we can all identify people like that we know. And this chap, from my experience, is not going to change that behaviour very easily. He's going to carry on in that role, and what he'll want, I think, from us as clinicians is to do the best that we can in the circumstances that he finds himself in. And this comes back to that whole matching, the intersect between the medical model and the patient model of illness. So we come back to the previous discussion about his ideas and concerns and expectations. And you'd certainly want to be very clear about what he wanted. Was this an incidental chat with the nurse when he had his regular diabetes check? And, was there any serious intent behind it to make a difference to anything? Did it come from the nurse who was just raising it because she recognised it was imperfect? Or did he really want something different? And that's what we'd want to establish first. If he did not, it is really very difficult. You'd start from that position, recognising it was very difficult, and start to explore with him what he really wants in life. But it's got to be what he wants rather than what you want. I want as a doctor. I can't impose anything on this guy, and if I try to, it'll fail.
That's interesting, but he is indeed 47-year-old, and he maybe not have a clear thought about what the complications that will come in 10, 20 years are going to be. So how do you give the autonomy, let's say, to the patient when you as a doctor also have the responsibility to care for his health, let's say?
Yeah, it's a fascinating dynamic, isn't it? And what I'd say in this context is that we are only ever advisors in our role. We're not imposers. We can't impose ourselves, and we shouldn't impose ourselves on individuals. And so whilst we have those concerns that we can share with him, what we know about doing that is that threatening doesn't work. So we know very well there's a lot of work to do with smoking about how to change behaviour. And what we know from that is threats don't work. What seems to work is getting people to an understanding that the things that really matter to them might be affected by their smoking. So for example, we might be bothered about for cardiovascular disease in diabetes or smoking, but the individual might be worried about their teeth falling out. And that's the single thing that makes them make a change to their behaviour. And so what we'd do in this circumstance is try and explore with that person where those soft spots are, where those things that really matter to that individual are, that might result in a personally driven behavioural change and an eventual improvement in their outcomes. And that might be an exploration about their family history. Their parents might have done the same. Type 2 diabetes is very much genetically based, so there may be some history there that he hasn't revealed to you. There may be some concerns that he has about his family and what happens to them if he's not around, those sorts of things. But you just don't know. There's an exploration to do with him.
With his unique lifestyle factors, let's come with the assumption that he says, hey, I would actually like to change some aspects of my life. What can I do? How would you then approach that?
What would normally do in that circumstance? I can't tell you how difficult this is. We fail at this very frequently. But what we'd normally do is explore those areas where we thought there might be some room for change. He's unlikely to change his job, but he might, for example, be able to change his ability to be able to exercise, the way he gets to work, how he manages his life, what he does at the weekend, what he enjoys doing, and we'd start to explore that with him. I would say the single most valuable thing for this chap from a medical perspective that he might be able to do is exercise. It's not a medical thing, it's a social thing. And if he exercises regularly, apart from his mental health improving, he's very likely to improve his diabetic control. He may even reduce his requirement for medication. His weight is likely to improve, and you start to get into a position where the deteriorating diabetic control is at least arrested and might be reversed. And that's without anything to do with medicine. This is all about behavioral management.
Mm-hmm. But how do you approach it? Because I've noticed that in the general population, there is this idea that, I go to the doctor, he's going to prescribe me medicine, that's what I expect. But then you come with the advice, you should exercise. How do you give that causal correlation between exercise and his teeth not falling off, let's say, which is important to him? Because I can imagine that the patient won't really directly see that.
Yeah, that's interesting, isn't it? And in the UK, and I'm not sure what it's like in the Netherlands, but in the UK, there's a large program of medical education around diabetes. So there's different programs for different circumstances, depending on insulin requiring and other circumstances. So this is all about education. It's ability to be able to get people to start to think again about their life, to be in touch with and join Diabetes UK, the organisation that gives advice in all sorts of areas, to do with cheap car insurance and other things that are non-medical as well as medical things, and starts to engage with their illness and take it to a level of seriousness that they perhaps haven't done before. But it's education rather than imposition.
Mm-hmm.
So if I was then to summarize what I would take away from this is it's you be there for the patient, you provide them with information and support, and over the journey of your care you guide them into the correct or into a development that would be beneficial to them, and it's a process. That was what I'd take away. It's
very definitely a process over a period of time, and that's the great joy of general practice. You have that longitudinal relationship with people.
And then my next question would be, looking at his specific management, are there challenges that you see in this case that would be unique to how you would manage him? And are there things that you're worried about? Are there things that you would look out for?
If we start to get into the medical management of this person, and if we get to a position where we think that he's not going to do what we think are the best medical things to do, which are around weight loss and exercise, in my view, and we start to think about medication to try and improve his vascular risk, then we, like the other person that we discussed, we'd start to think about an SGLT2, and we start to raise that profile with him. Now, sometimes when we do that, it has an interesting effect, because the one thing a young man doesn't really want is to be medicalized. He wants to feel fit and active, and it might be one of the issues that's underlying this, that his compliance with the medication is poor, because he doesn't like being ill. He doesn't like having the pillbox by the side of his bed. His wife sees him as an ill person rather than a fit person, and he sees himself in that way. So once you start to introduce more medicine to somebody like this, it very often has the opposite effect and galvanizes them towards what you'd really like them to do, which is the former explanation. So there's lots of play in this. There's lots of psychology and personal interaction stuff.
That's true, but we also have some patients that actually, when they have a disease that's not very visible to the outside, that they do want to be medicalized. They do want to have that aspect in their life so that they show to others, I struggle. How would you approach that kind of patient?
Yeah, complete other end of the spectrum, the people who want to be medicalized. And the way we deal with that, and I know this is different in different countries, but the way we deal with that in the UK now is to try and empower those people to take control of their own world and their own health, and not induce that dependence on them. If we look back over the last 30 years, that caricature of the doctor with the tweed jacket peering over their glasses and saying, "My dear, what you must do has gone," and it's good that it's gone. So the whole task with people like that is to allow them to take control and empower them to do that.
Then, looking specifically at the glucose management, are there unique challenges that are brought through periods of fasting or periods with stressful jobs where you can't easily manage your glucose, especially looking at medications? Are there things that you would consider in type 2 diabetes?
The reason that metformin is used as the drug of choice in the vast majority of type 2 diabetics is that it does not cause hypoglycemia. And those issues about fasting during Ramadan are relatively easy to manage with metformin. It may be that blood sugars come down. It may be that you don't need to use the same dose. You may be able to reduce that a little bit. Even if you don't, he's unlikely to get into difficulties. Theoretically, there's a slightly higher incidence of acidosis associated with biguanide use in that context of fasting, but normally in this circumstance, it's not long enough to make a real difference. So you might have that discussion with him. He might drop his dose during Ramadan. Type 2 diabetics don't normally check their blood sugar regularly. We don't encourage them to do that. That practice does differ around different countries, even in Europe. But in the UK, we don't.
Why is that?
Yeah, that's a good question, isn't it? Because they all used to do that, and to be a bit careful about what I say here, but the drug companies used to encourage that. But what we know is that it really makes no difference to long-term management. Type 2 diabetes, as I said before, is all about vascular risk. And the HbA1c is at least as good a marker to spot checks on blood glucose in the context of something that's a relatively stable long-term illness.
Fascinating. Yeah, I mean, I've also talked to people who have a lot of anxiety about their blood sugar constantly, and they'll constantly check it, and then it'll be going up and down, and they'll take, this is type 1 now, but they'll take their insulin, and then they'll pump down again, and then they'll eat, and there's, I think sometimes, hey, if you just kind of forgot about it and ate reasonably normal, maybe there's a bit more stability there. Anyway.
Exactly that. It's not necessary, in my view, to check blood sugars in the vast majority of type 2s who are not insulin requiring.
So Cassie was a 49-year-old with a 2-year history of type 2 diabetes. She's been considered for statin therapy. She attended the Practice Diabetes Clinic with following test results: HbA1c 55 millimole per mole, cholesterol of 5.8 millimole per litre, triglycerides of 3.4 millimole per litre, HDL cholesterol of 0.9 millimole per litre, non-HDL cholesterols of 4.9 millimole per litre, an ALT of 87, a gamma GT of 85, ALK phosphates of 98, and a bilirubin of 18. The albumin is 42 grams per litre, the EGFR is 85, and the blood pressure is increased on 148/92. She has a BMI of 32.1 and a waist circumference of 89 centimeters. So Cassie's regular medications are metformin 1 gram twice daily and lisinopril 10 milligrams once daily. She's a smoker and she drinks occasionally, reporting not more than 8 units a week. Casey has struggled with weight management and physical activity due to her demanding job as a shift worker in a high-stress environment. Additionally, Cassie acknowledges occasional lapse in her adherence to her diabetic medications, often linked to her regularity of her work shifts, and she comes to the practice concerned about her family history of cardiovascular disease and what that might mean for her. When you see a patient come into your practice like this, what is your initial thoughts and approach to management?
Isn't it? It's interesting when we have these discussions. The third case, and what we come back to every time is not the medicine of this. So the reason that this young lady, and she is relatively young, is in difficulty, and perhaps the reason she's even diabetic at all is because of her lifestyle issues. She carries too much weight. She may be drinking more than we would like. She's drifting towards the metabolic syndrome, and the liver function tests would make one consider whether she had a fatty liver as part of that whole syndrome. So this is lifestyle. It's all about lifestyle. My strong suspicion is that if she was, if she had a BMI in her early 20s, she may not need any diabetic medication. She may not need any antihypertensive medication. And the job here is to start to explore with her what the opportunities are to make a difference to that pattern of behaviour. There is an issue about the alcohol. With those liver function tests, you'd want to explore with a fairly critical eye whether that assessment of her intake was accurate or not. And I suspect it probably isn't, but and that may be a critical factor in how you approach her and manage things.
How do you evaluate and weigh up risk factors?
Yeah, it's interesting, isn't it, that we medicalize this, because it's very obvious to anybody hearing that story that this young lady has a very significant vascular risk. In the UK, we use something called a Q risk, which is a composite of the key vascular risk factors, smoking being one of them. And the normal management of anybody with a vascular risk over 10% is to start to think about statins with them, and that's the discussion that we might have with this person. My perspective on this is that isn't the most important thing for her, and is well down the list of importance. The important things for her are possibly the alcohol, if that history is incomplete. Certainly the obesity, and top of the list, of course, is the smoking. Those things are going to be of maximum benefit to her in long-term fitness.
Yeah, and does her family history of cardiovascular disease worry you?
Oh yes, it does. The genetic factors are very dominant and feed into that Q risk calculation.
So I can imagine you can't bombard the patient with different advices. So what would you prioritize?
Yeah, and it's so fascinating, isn't it? Because we come back to that same thing that we've talked about with the other two cases, that you start at a place where she can recognize that there's an issue, and you think you might be able to make some progress, and you pick the low hanging fruit and try and deal with that first.
And in this case, can you see what the low hanging fruits might be, or is it more than necessary to have a good conversation first?
Well, it's certainly good to have that conversation, but the low hanging medical fruit might be different from the low hanging personal interest. My low hanging fruit is to get her off the cigarettes.
I don't think that's her low-hanging fruit.
It probably isn't. That's exactly the point.
Would you like to read?
Yes.
I'm good.
Beautiful.
I'm going to call him Jeffrey. Jeffrey is 46 years old and a diagnosis of type 2 diabetes since his late 30s. He comes to seek help for erectile dysfunction. Jeffrey is remarried with a younger wife, and they are keen to start a family as soon as possible. He's worried about the effects of his ED on their relationship. Jeffrey has struggled with managing his diabetes over the years. He admits to irregular medication adherence and occasional lapses in dietary control due to work stress and personal life adjustments after his remarriage. Jeffrey expresses significant concerns about the impact of his ED on the relationship with his wife. He feels pressure to start a family soon due to their age difference. Moreover, Jeffrey's occupation is a high-level executive demands long hours and excessive travel, leading to irregular sleep patterns and limited time for self-care.
How would you start in this patient finding the etiology of that?
You know what has occurred to me sitting listening to this so far is that at no stage have we discussed examination of the patient, and that's a fault of mine really in not weighing on that message. It's really important to do. In this case, it exemplifies that. But the one thing you'd want to do is a full neurological examination and make sure that there wasn't any other evidence of neurological disease. It's very likely that there is not, but it needs to be done. There's more history that needs to be taken as well, because you need to understand what this gentleman's alcohol intake is like. It's a very dominant factor in erectile dysfunction. But what's really important is that he's come wanting that to be dealt with. And what we very often find in diabetic care is that people don't mention it. In fact, it's one of the teaching things that we try and teach people to do, is to inquire about this in a very straightforward way. Even if they don't mention it, because men will not mention it in the vast majority of cases in the UK. It might be different in Holland, but in the UK they won't mention it unless you specifically ask them about erectile dysfunction, and then they breathe a sigh of relief and are delighted you've asked them if it's a problem. So having mentioned it, the history is all important here, and you want to know all sorts of things about this chap. You want to know when his erectile dysfunction started, what form it takes. Is it he has a difficulty getting an erection? Is it he has difficulty ejaculating? Is it that when he gets an erection it disappears quickly? Is it that he gets morning erections still? When did they lapse? If they have lapsed, if he still gets morning erections, you know that the neurological and the vascular components are likely to be intact. And so that history is really, really important. And if he does continue to have morning erections, then the likelihood is that there's no pathological explanation for this, and this is psychosocial, psychosexual. So history, absolutely paramount importance. Many years ago, when we started to pull this history apart and thought that we were dealing with something that was psychosexual, particularly in the context of a new relationship and demands for fertility and that sort of thing, we would have gone down the psychological route. But most people in this field now, because of the ease and advent of sildenafil and all the sons of that particular drug, would think about offering a solution which provides an erection as a tool for that individual to gain confidence back that it might provide a solution for him, and then once he's gained confidence, the issue diminishes. So the way we manage this has changed over time in that circumstance where it's psychosexual. If this is not psychosexual, if you reach the situation where he doesn't have morning erections anymore, and you think there may be a pathological element to it, the course is very, very different. You know, there's certainly some need to look very hard at his peripheral vascular tree, and to look for evidence of neuropathy very, very hard. And then we get into all the what can be done about it, and that depends on what you find. If you find nothing, which is the most common situation, there are a range of opportunities that we can talk about if that's of interest.
Yeah.
Okay, so the first thing to say is we can always achieve an erection for men. Always, never use that in medicine, but and the simplest, commonest way to do that is use of a mechanical pump. So that's why I say you can nearly always produce an erection for people. It's not always a desirable thing. It's not a very comfortable thing to do, but to produce a vacuum, provide a vacuum pump and put a penile ring on once that develops tumescence is non-drug, very effective, and you can always achieve that. And that ring's left on during intercourse, and then taken off afterwards. That's the non-drug option. I've already talked about sildenafil and all the sons of sildenafil, which are now the base normal treatment for erectile dysfunction and effective in a great number of people. And the same drug is available as a pellet that you can put down the urethral meatus. It's not often used, but it's available, and it's slightly less effective than the similar drug salprostatil by injection. Now, injection sounds awful. Injecting the base of the penis sounds absolutely terrible. But for those who do use it, is very effective and very well tolerated. It's surprisingly so. And a few of your patients use that, but the vast majority find some form of sildenafil that's effective enough. And the great joy of that, of course, is it doesn't stop the act of intercourse. It doesn't put any gap in there. It can be taken within some hours beforehand, and all the softer elements of that relationship are maintained in an individual.
Mm-hmm. And placing this erectile dysfunction in the bigger idea of diabetic neuropathy. So is the core message to us that you can't really treat and reverse that neuropathy? You can just lessen the symptoms?
Diabetic neuropathy is a very unusual cause of erectile dysfunction in the absence of other evidence of diabetic neuropathy. So if this was a problem caused by that, you would expect to see some sensory changes in the peripheries. But the principle is right. Of course, once it's there, it's fixed, and you can't. You may be able to arrest the progress by very tight management of diabetes, but you won't be able to reverse it.
Do you have any advice for young doctors and professionals that you would like to share, that you think would meaningfully help them on their way in their career in medicine?
The one thing that rests from this conversation that we've had today is never do anything unless you're confident that's what the patient wants.
Short and sweet, beautiful. I like that. Okay. Well, thank you. Bedankt voor het luisteren. Als je hebt genoten van deze aflevering, like en deel met je vrienden en collega's. Wij zijn ook te vinden op LinkedIn en Instagram. En tot de volgende keer.